Hi everyone, let's go ahead and get started. My name is Holly Fernandez-Lynch and I'm an assistant professor of medical ethics here at Penn. Welcome to the February session of the Research Ethics and Policy series. Before we really get into it, let me thank our co-sponsors, without whom the series wouldn't be possible, as well as Mary Pham for her excellent assistance behind the scenes running the series. In terms of our spring schedule, I did want to flag for you that in March we have 2 speakers slated. On March 2nd, we'll be joined by Allison Bateman-House from NYU, and she'll be presenting on the topic of pre-approval access to investigational products for treatment use, and we'll have commentary from the head of the Abramson Cancer Center, Dr. Bob Vonderheide. And then on March 16th, we'll have a special session with Dr. Greg Gonzalez from Yale. Remember, he had been rescheduled from the fall. He's going to discuss the role of patients and advocates in research, something that he has a lot of experience with as an HIV patient and advocate himself. He's also winner of the 2018 MacArthur Genius Award and not to be missed. So even though it's outside of our regularly scheduled meetings, I would really encourage you to try to make room on your calendar to come to that. And then my last note is just a flag for this research ethics online course that the Department of Medical Ethics and Health Policy has created. It's available for free for learners at Penn and CHOP, and also eligible to satisfy human subjects training requirements at those entities. The course is also available to learners outside of Penn, including for free to learners in low and middle income countries. So if you have audiences that you think might benefit from this course, please come see me afterwards or check out the website, and we're happy to answer any questions you might have. And now on to the main event. It's my pleasure to welcome Dr. Karen Glanz, who's presenting today on ethical issues in design and conduct of community-based research. Dr. Glanz is George A. Weiss University professor here at Penn, where she's also professor of epidemiology, professor of nursing, and director of the Penn Prevention Research Center. She's an influential public health scholar whose research is focused on cancer prevention and control, theories of health behavior, obesity and the built environment, social and health policy, and new health communication technologies. Dr. Glanz has a long history of leading community-based health research and programs. She's currently the director of the Community and Collaboration Core of Penn ITMAT, as well as the Recruitment Outcomes and Assessment Research Core, which has the great acronym of ROAR, at the Abramson Cancer Center. So thank you for being here, Dr. Glanz. And if you are so inclined to tweet, the hashtag is PennRex. Thank you.
Thanks, Holly, and good afternoon, everybody, on this beautiful February day that you're not outside having picnic lunches, you're inside here. So the challenge of balancing the scientific rigor, community context, and ethical concerns in community-engaged research has become increasingly complex and keeps changing over time. Ethics affects the scientific, the methodological, and the practical concerns that we encounter in conducting community-based research. There are different kinds of ethical issues. I'm going to try to touch on a couple different ones. Ethical issues related to research participants, professional relationships and collegial relationships, and relationships between science and society. What are we trying to accomplish and why? With this type of research. Community-based research has overall a little bit of a glow because we think it's good to work with people, it'll help them, it'll help improve their health, their lives, etc. And yet, you can do all the planning that you want, but it's actually more likely that ethical issues are going to arise during the project than in necessarily planning it. So that requires an ability to deal with the unexpected issues as they arise, to solve problems, and there are really no easy answers for many of the things that we encounter. So I'm going to present, in addition to some background, I'm going to present a few cases, and I want to encourage you to speak up and give your opinion because people may have different points of view. Each of these cases is based on something that actually happened. In some cases, they've been slightly modified to conceal, protect the innocent or the people who are challenged. And several of them are composites of experiences that I've encountered over the years. So I want to start with the first case. The headline is Community Research Assistant Noncompliance. So when we do community-based research, it's encouraged, considered a good thing to hire people from the community to actually be part of the research, that they have entree into the community, that it's a way of giving back, et cetera. So here you are conducting an NIH-funded study to evaluate the effects of community education to reduce child lead poisoning in a minority community near a former mining site. This is a Superfund site. So there's your Superfund site. For those of you that aren't familiar with this, the mining has gone on for many, many years, and it has left behind a lot of toxins in the soil, and they spread out. This is often in rural areas near where people live. So the study involves collecting behavior and blood lead level data in 3 to 5-year-old children in the community. So behavior data. So do not play in the dirt or around the mulch. So some of the recommended behaviors for reducing lead poisoning in children is that they don't play around in the dirt and get their hands where all the toxins may, kind of enter their system, so that they should play on concrete or playgrounds that are built. So it's one thing that is encouraged and is asked about in the study. But the blood lead levels is really the bottom line. That's the most important outcome of this study. So you hired and trained local community residents to complete these tasks. The community research assistants were trained in phlebotomy, human subjects protection. They were certified. They've had a lot of supervision in their practice sessions. Then, about 6 months into the study, you hear from one of the research assistants that another RA is not drawing blood from the children, but using their own blood for the study and collecting their own blood and labeling it as if it comes from these kids. The reason that they suspect this is happening is that they feel uncomfortable sticking little kids with needles, and therefore they feel like they're doing something, to avoid hurting the children. You also sense there might be some interpersonal conflicts among the research assistants. So these are just accusations. So what is the ethical dilemma that you face, and how would you handle the situation? Remember, there's no right or wrong answer here. What would you do? Yeah, Robbie. Fire the research assistant. Okay. And anybody else? Agree, disagree, do something else? Susan?
Well, you don't know the truth because you're worried that there's may be falsely accusing you.
So what would you do?
Well, I don't know, but I wouldn't immediately fire you.
Amory?
I think I'd have to just stop. And that would kind of figure out if there's a way that you can bring in both research assistants, but it could become like
Anybody else? Holly?
Could you test the blood to see if there's a lot of samples from the same individual?
Certainly a good first step to try to get at, whether this is even plausible, this accusation. Anybody else? So that answers the question, what would be your first steps? How would you protect the integrity of the data and the project as a whole? Maybe that goes back to Robbie's answer.
Right, so the person's admitted that they are.
They haven't, no one's admitted it.
Okay.
They've only been accused.
The reason given is that they feel uncomfortable.
Well, that's the reason that the accuser says, so-and-so told me I'm using my own blood. I hate sticking these kids with needles.
Definitely a deviation from protocol. Probably IRB.
Yes. So that's a good solution going forward, but it may not resolve what's happened in the past. Other thoughts? Steve?
You probably have to sequester the samples of the data from the suspect blood draws until you figure out.
Anybody sense that there could be some backlash out of this? Like you're worried about your study and the integrity of your study, but you hired someone from the community, like you might fire them. How would you, yeah, Jade?
You can talk to the community leaders about why an RA might feel uncomfortable with this.
That's certainly one thing you could do. Yeah.
I think that would just talk.
Like what you can do to salvage the study if it's been compromised in some way. So these are all really good answers. Let me tell you a little bit about what happened. This was a really big deal. It was like a lot of lawyers involved. Federal government funding, Superfund site, communities angry that their children are being still poisoned after all these years after this mining took place. So the Superfunds were set up to clean up and to try to make, to kind of reduce the damage, reduce the harm to future generations. The university and the IRB all had to be involved. The investigators had to be involved. And there was a question of who's at fault. When you have a research assistant of any type who misbehaves, anybody ever have that happen? I know we got some seasoned researchers here. Easy to fire people, right? It's not easy to fire people if they just came from the university in the first place. So again, the potential repercussions with the community. So it took on a life of its own, actually, as this situation arose. A lot of things that weren't foreseen. By the time this happened, actually, the main principal investigator was no longer even living in the place where at the university. It had moved to another university, but was still principal investigator. So eventually it got worked out, but not without a lot of, careful and potentially difficult accusations, legal and personnel, and for the research. So yes, the samples were found to have come from the same person, many of the samples that RA had collected, and they could not be used in the research. It didn't compromise the study as a whole, but it led to kind of a tightening of the reins. So someone suggested accompanying the staff. That is, in fact, an important remedy to make sure this doesn't happen in the future. It's also really discouraging for research staff who think that they're somehow empowered to do the work. So there's a lot going on there. So community engaged research, let's just take a step back and I'll give a working definition. The reference at the bottom, Principles of Community Engagement, second edition, it's 9 years old now, but there's not a third edition yet. That was developed by the NCATS, which is the National Center in the NIH, which funds the ITMAT and the CTSAs. And as leads for Penn's Community Engagement Core, we participate with this national group, which wrote this book, and it's considered something of a guiding document for community engaged research nowadays. So community engaged research is defined as the process of working collaboratively with and through groups of people affiliated by geographic proximity, special interest, or similar situations, such as a common health issue, to address issues affecting the well-being of those people. And the general goals of community engaged research are to involve community members or organizations in research as participants and investigators, which we'll get to that, to create a mutually beneficial, trusting relationship between researchers and participants, and ultimately to improve the overall health outcomes for the targeted area. Much of community engaged research has its roots in social action, and you can see these different kind of fields: feminist theory, environmental justice, that would certainly apply to the Superfund site and that research, community organizing, participatory research. These are all the roots, and when the tree grows, it's a little bit of a mix of everything that came in from the roots. A lot of community participatory research in the 20th century got its grounding in principles related to minorities and disadvantaged communities. So the work of Paulo Freire, who some of you may be familiar with, who wrote a book, among others, called The Pedagogy of the Oppressed, proposed kind of a new way of educating disadvantaged populations such that the educators or the privileged would take off their colonial appearance. So it wouldn't be seen as like, we just know better and we're going to help you, but rather engaging the community in helping to solve problems and identify problems that were affecting them. There's a continuum of community engaged partnership models. Originally this talk was called community-based. A lot of people talk about community-based participatory research, or CBPR. How many of you have heard that terminology? It's pretty widespread. CBPR texts started coming out in about the 1970s, 80s, kind of building on Freire's work, and they were fairly strict in the principles that should or must be used for community-based participatory research. That was on the community-driven end of the continuum. So the idea was that the community would identify the problems that should be addressed and be an equal partner throughout with researchers. Now, if most of you think about the research you do that might affect communities, you may have a particular expertise and you may not have another expertise. So my work is largely in the area of chronic diseases, chronic disease prevention, a few other areas too. But if I go into the community and they say dilapidated housing and guns and opioids are our problems, what am I to do? Am I to say, oh, okay, I have some colleagues that can work with you. But actually we know epidemiologically that chronic disease kills people and kills more people in that community maybe than in more advantaged communities. So we know it's a problem. So there's kind of this blending, and now we recognize, and it's more widely recognized, that there is this continuum and that it's not like forbidden for a researcher to have an idea and to approach a community and to work with them and to engage them to carry out that idea if they can see some benefit to it. So for community engaged research to succeed, we need to recognize the diversity of the community. This is really important. I can't tell you how many times I've had somebody say, you need representatives of the community. Well, when you think of a neighbor, even think of your neighborhood where you live, but think of a disadvantaged community. Is there one representative? Is there going to be one opinion? Not necessarily. There's going to probably be a mix. Need to mobilize community assets and strengths, develop the community's capacity and resources. So the idea being that you don't just take research data from the community, but that you contribute. And last, and something pretty difficult that they don't teach us mostly in our research training, is to be prepared to release control of actions or interventions and be flexible to meet their changing needs. So I had a paper that I once wrote. It was a dissemination trial. It was a national dissemination trial, and during the first year, we had to kind of work out some of the details of implementing our intervention that had been implemented locally and been found effective. But when it was done locally, we sent people out, and they were on site, and they spent a lot of time on site. And when we were doing it in 150 sites in a handful of cities around the country, we had to get feedback about what would and would not work. So we wrote this in our design paper, and one of the critiques that we got was, I'm not comfortable with you're doing a randomized trial and, you know, adapting to what the participants want and are willing to do. But that really is the reality, and there's a balance there. It's not an all or nothing kind of a thing. So some of the challenges working with communities include how much do you collaborate, who makes decisions, whose research agenda, the risk of raising false hopes. From day one, when you ask someone for a letter of support for your grant, or you say we're going to budget for some money, for space, for people in the community, and you write a grant, I don't know about you, but I don't get 100% of my grants funded. And we have to deal with that. We have to bear that. We have to bear that with our colleagues, but our colleagues kind of understand the game. But with the community, it's tricky. We have to convince them this is a good thing. It's worth their involvement, but we may not get the funding. Sharing data and research findings, responsibility to establish a long-term relationship with the community. It is kind of a slippery concept or principle that some community participatory researchers feel extremely strong about. That said, I have seen some of my most adamant community participatory researchers develop a long-term relationship with the community for the funding period of the grant. And when the grant ends, it's often hard to sustain structures, relationships. It's definitely preferable to have a long-term relationship, but doesn't always happen all the time. And last is, how does a community define itself and its boundaries? There are all kinds of ways to define communities. As we said, it could be people with a common health problem. It could be people living in a particular area. And the question is, how do they define that? I've heard people say there are communities in West Philadelphia, but to the extent that those academics are living there, they're not like the real community. But really, they actually live there just the same. Community advisory boards are a common vehicle used in community-based research. They tend to provide structure to help frame the research question, to give feedback on data collection procedures, cultural appropriateness, to provide access to settings for interventions, data collection, to help interpret the results, and last, to assist with disseminating the findings and translating successful interventions into wider use or longer term use. All of these bullet points are commonly what is kind of dictated in community-based participatory research, and so they may or may not occur to a greater or lesser degree. As far as data collection, again, community-based research is very heterogeneous. We can be looking at individuals, groups, organizations, communities, geographies, political units. We can be directly talking to people, reviewing records, observing them. But ultimately, probably the most common data collection method is self-report surveys and interviews of people in various communities. And those can be in person or over the internet or by mail or by phone, et cetera. So let's kind of take a look at this through a lens of three basic ethical principles. I was looking this up because not being an ethicist like some of my colleagues, I was like, okay, these are the three that we talk about most often when we talk about research ethics. Then I saw the 8 ethical principles, the 7 ethical principles, the 4 ethical principles. So these are 3 that I think are pretty fundamental and relevant to community-based research. So 1, respect for persons, which is often also called autonomy, is that we treat people as autonomous human beings, capable of making their own choices. We don't use people as a means to an end, and that we provide extra protections to those who are vulnerable. Even within an institution like Penn, we can get a lot of different reactions to what does it mean to say that people are vulnerable or that a community is vulnerable. We all know that prisoners, children, pregnant women, et cetera, have special protections. Much of our research has taken place in low-income communities where there's a high proportion of minorities. Okay, we put in a protocol for a new study a few months ago, and the first thing that we got back at the first level of review from the IRB was, this has to go to the whole IRB, you're doing this in low-income communities. And, it was someone new. And we said, gee, we've been doing this I've been in Penn for 10 years now, and this hasn't been required in the past. And they cycled back and checked with their supervisor, and indeed, it was no greater vulnerability than people living in particular, neighborhoods. And of course, the protections were built in. Full autonomy means that people understand the information you give them about the research, they choose whether to participate or continue in the research, and that they're not coerced. So it involves informed consent, voluntary data provision, and avoidance of excessive inducements or incentives. So informed consent is not a document, but a process. And I think this is one of the key things to bear in mind. We tend to put a lot of attention on what is written in a document, what is the language that's used, how detailed is it. We're required to check a lot of boxes when we develop consent forms. So we have to cover this, the purpose, the procedures, any discomforts and risks, and what about that? So there's a lot of judgment calls in there, and there's a lot of judgment calls on the researcher's end, on the IRB's end, and on the community's end. Providing complete information may lead to a refusal to participate. One question is, can you do a randomized controlled trial in a community with the community's involvement? Can you randomize? What do you think? Susan thinks so. Why not? That's what I say. Why not? But it may take some additional thought. So we started a study, this is quite a number of years ago, where we had a community advisory board. This was a study of skin cancer prevention of kids going to swimming lessons at swimming pools. We had a community advisory board that represented the kind of organizations we were working with, swimming pools, recreation centers, et cetera. And the pilot study went fine. There was no control group in the pilot study. But then in the main trial, we were going to have randomization so that some pools, the pool was the unit of randomization, got the program and some didn't. And our community advisory board said, oh, no. Nobody's going to agree to be part of this if you tell them they're getting nothing. In other words, we wanted to collect data from them. Observations, that's pretty low burden, but we wanted to survey parents and kids that were coming into the pools, and they said, you've got to give them something. So we did. We actually developed a whole other attention-matched curriculum based on injury prevention that was separate from the cancer prevention, and we got equal participation. So it's, you know, it's kind of the methodological issue and the community relations issue that affected us. Providing complete information may lead to behavior change. You tell people what they're getting and what someone else is getting, or biased responses. One of the biggest issues that comes up in community research that is less common in, say, clinical research is, do you need the consent of the group, the organization, or the community? So that's our second case. True case here, you're conducting a descriptive study of the built environment, and you're doing it in several neighborhoods. So you're not just studying low-income or disadvantaged neighborhoods, you want to contrast them with some more affluent neighborhoods. You want to learn about health disparities, social determinants of health. You define the neighborhoods as census block groups, and you're able to get the census data on socioeconomic status and race from the census. So you don't have to ask people who live there. You're going to look at, a lot of the research, this is going to involve observation. Looking at the condition of sidewalks, streetscapes, outsides of buildings, and also looking at food stores to see what kind of foods they sell and what their price is for different kinds of foods. So question, do you need permission from the neighborhoods or the communities to collect these data, and why or why not? Robbie's shaking his head no. Say more.
Or you're fired the neighborhood.
What'd you say?
Fire the neighborhood. You're not collecting personal health information.
Other people agree, disagree, have a different perspective on that? Yes? About the food stores. Yes. Sorry? Okay. So you're not on public property necessarily when you're looking at food stores. Any other thoughts? Yeah.
I think typically that you need to get like.
You? It might be informative, but I'm not, but do you, maybe you don't need to. Mary? No, but it's community engaged, it's community based, it's in the community. So that's a good point. Steve?
So I'm not convinced you need to ask for permission. It's private property, like you have every permission to walk in there and look around. Or that some of them would say, well, no, you can't be in here.
Good point. So I'll tell you what we did, what we do. This is not exactly the study we did, but parts of it are. And what I think one should do. We did not ask the communities per se. These are census block groups. Now, in Philadelphia, in urban Philadelphia, we have neighborhood groups, and they're structured and they're organized and they're fairly well defined, but you're not even necessarily doing like Spruce Hill or, west of Walnut or whatever to do this. On the other hand, it might be beneficial. It goes back to your focus group idea. It might be beneficial to establish connections with some community serving organizations so you can get some clue as to what you're looking at. And this is not just in disadvantaged communities and more advantaged. So as it turns out, in this study, we also did some interviews and surveys. And so we connected up with the YMCAs, the libraries, et cetera, just to learn a little bit more to inform our on-the-ground work. As far as the food stores, been doing this for over 15 years now, and it's being done all over the country, all over the world from work that we started in Atlanta. What we found was if you go into a big supermarket, no one notices that you're there, no one cares that you're there. If you looked around and tried to find the manager to tell them that you're taking notes on what foods are available, remember, this is not an intervention. They kind of would go like, I don't know what you're talking about. We're owned by a corporation that's, not even local. But when you go into the corner stores, you go into convenience stores, and you've got your notepad or your iPad or your clipboard, you become pretty obvious. And so what we did develop was a letter simply giving information about what we were doing, that we were not the competition, that we were not the health department, which was great until we were working with the health department. and then we said, we are working with the health department, but we're not here to, inspect your, the cleanliness of your store. So, we did that for goodwill, and yes, to Steve's comment, we did get turned down by some, and some of it was a bit confusing. We worked with a group in New Orleans right after Hurricane Katrina. Well, it was about a year and a half after, long enough after that the food stores were reopened. They were very interested in seeing if the reopened stores would be healthier than the previous ones. And we took a group out to train, and they cleared it with the store managers. And then on the day that they went out, the store manager wasn't there. And they said, but Raul said we could do this. They said, Raul's not here. So, it's a little bit twisty. And we get about an 80 to 90% agreement rate. I also had staff come back from store visits and say, the store manager won't let us do this, blah, 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 blah. Then they said, then they changed their mind. Then they said it was okay. And then the store owner called me, because my name was on the bottom of the letter, and said, tell me more about this study. I'm thinking about whether we should participate or not. And I'm like, you already did participate. So, it comes and goes. But then things get interesting, because you're beginning your study. You selected these neighborhoods, as I said, based on census data. And it turns out that you have colleagues at a different university. That's in one of the neighborhoods. Now, actually, these pictures, I don't know if anyone recognizes it. That's near Hopkins, and this is actually near Carnegie Mellon, neither of which is the neighborhood I'm referring to. But you tell your colleagues that you're working in Northeast Park, and you say, we're doing this assessment, observations only, and you might be interested in some of the data we collect. Maybe you can use it for something in the future, for an intervention, whatever. Instead of being pleased that you told them about it, they're very upset that you are in their neighborhood. Do you need their permission to conduct research in the neighborhood? And why or why not? Very true story. Someone over here.
Probably don't need the permission, but
Other thoughts? Depends on which individual you ended up talking to and how upset they are. The answer is really exactly kind of what you said. It's good to have a line of communication so that it doesn't erupt into a crisis or a major problem. I don't think you have to. Of course, they don't own the community. They don't have, you're not, invading something that they officially have ownership over. But it takes me back to something one of my professors said when I was a doctoral student and I was working with an organization and they wanted something on a paper that I thought was technically incorrect. I was a very smart-ass young doctoral student, and I said, but they're wrong. That's not the right terminology. They say that they want it to be said this way, but I think they're wrong. And what he said to me was, do you think you might ever want to work with them in the future? So I think therein lies the answer. Do you want to have a relationship? Do you want to keep that relationship peaceable? You're not going to make everyone happy. They may not give you what they consider to be their permission, but at least you may have a dialogue about the issue. All right, so turning back to informed consent and literacy. So with low-income and minority populations, we have to be especially concerned about the readability of the information that we give them. One of the biggest questions that I've encountered recently is, do you have to translate your consent forms and your survey forms and your interviews into all languages that you might encounter in that community? Do researchers have an obligation to do that? A lot of times we'll write a protocol and say it must be English speaking. And they'll say, but that excludes a lot of people, or it excludes some people. Look at a city like Philadelphia, we have a lot of immigrant communities and people who don't speak English. Are we obligated to translate everything? I think it depends on the research question. And if the community has a large enough representation from a particular linguistic group that is non-English speaking, then you might consider, is there a way to accommodate that? Interestingly, we did that in our large dissemination study of the swimming pool study. We had a lot of sites in Arizona and Texas, and they told us they wanted Spanish language surveys, and they said, we'll be able to get you a lot more participants if you translate into Spanish. So we did that. It was very interesting because we found out that the people who took the survey in Spanish were different from Latino, which is what we called them at the time, or Hispanic participants who took it in English. There was an acculturation difference that affected their health behaviors. So in terms of high-risk and vulnerable communities, a lot of community-engaged research is focused at minority and low-income, and health equity concerns, health disparities, but also funding priorities drive this trend. And what we might encounter is distrust of researchers. And I don't need to go over it, but the Tuskegee syphilis study, other studies that have been blatantly taking advantage of communities, the HeLa cells. So formal safeguards and reforms may be insufficient. And I think we just need to be aware of this. One thing I have noticed is that some communities that I've been involved in with research do not know about the Tuskegee syphilis study, but the researchers want to tell the story, and then the participants say, oh gosh, that doesn't make research look very good. So we have to, again, think about that and think about who represents the community. One last area of autonomy is the use of incentives and undue inducements. And here at Penn, it's become pretty commonplace to use incentives in behavioral economics related studies. But again, the question still arises with gifts, payments, reimbursements. They usually don't compromise ethics if they're not unreasonable or they're not given to appear as coercion to participate in a study. And I think I will leave that one there. Privacy is another issue that takes on a different shade in community-based research than it may in clinical research. When there is observation, when there's linkage of information to subjects' names, when we're doing things like door-to-door surveys, have to be clear about the difference between confidentiality and anonymity. If we want to do something where we want to go back to the same people for follow-up, confidentiality is certainly appropriate, but anonymity would make that impossible. It raises the questions when you're in or near people's homes, work settings, schools, et cetera, how confidentiality is treated, and that comes up again if we're including community participants in conducting the research. So in small communities, it may be more possible to identify people. People may know that survey researcher that you hired that knocks on their door. If they open the door and are conducting a survey and they see signs of domestic abuse or guns lying around or signs of drug use, are they required to report it? What's the obligation? What goes along with that? We have actually talked about the online IRB training that your department has created. We, working with Penn's IRB, developed a community participant research training so that community members who are not employed by Penn, so they can't actually be in the Penn system, can deal with some issues like this and what their obligations are. Another question that comes up, should you even name the communities? In this age of maps and mapping and geospatial analysis, a lot of people put up maps and then people say, maybe we should just call it community A and community B. I tend to lean on the side of naming communities, at least in a general sense. So talking about beneficence, doing good, having the interests of the participants in mind. Talked earlier about community expectations. As researchers, we are obligated to equipoise, to be asking a question to see if something makes a difference or doesn't make a difference. But often we're in the position of having to sell the research to the community by the prospects that it may be helpful. And if it isn't helpful, how do we deal with that? That's even once you've gotten the funding. So we have that obligation to maximize the potential benefits. We also have the question at the bottom of providing referral and follow-up. If we're doing some kind of screening, whether it's a survey-based screening or a health exam, to make sure that people who are at risk receive services. So this is a really challenging issue. I work in the area of cancer screening, and we want to get people screened because cancer is more treatable if it's found in an early stage. But what if someone doesn't have the insurance or doesn't have that primary care doctor or regular service provider? We have to be prepared for that and find a way to handle it. So in the informed consent and adverse event area, things can go not in the way that you planned. So just going to quickly give you this case where doing a study, a parent asked for the survey, they don't like what they see, you have to disclose it to the IRB, and they say the whole study should stop in the meantime. And how do you handle that? So I'll quickly go through this. So you're conducting a large NIH-funded tobacco prevention study in 24 middle schools, 3,600 kids. You have to get parental consent, and you've carefully prepared everything. And one parent asks for a copy of the survey. Remember, this is out of 3,600. and they see the survey and they see the questions about whether kids recognize specific brand tobacco ads. The reason that's in your survey, our survey, was because previous research had showed that kids are more likely to take up smoking if they recognize those. But the parent is really angry because they think the study's funded by the tobacco industry. And you talk to the principal, you try to talk the person down, they calm the parent down, but you have to report this to the IRB. You report this to the IRB, and they say, okay, you need to revise, even though it was already in there clearly stating that this was funded by the National Institutes of Health. You have to clearly make it even clearer, and you must stop all data collection until the revision is approved. And that's going to take 2 to 3 months. This isn't today, although in some places it does take that long. What do? You can only collect data during the school year. The school year is going to be over. How do you handle that situation?
It would be a way to prevent it, right, is to let the parents know about the survey before it goes out and have, questions of you as the researcher, that they're not caught by surprise. Maybe include some kind of like ethics.
Other thoughts? So we actually did things like that. We had community advisory boards, but not very many people show up. Yeah, Robbie?
Let the parent know that your child.
Yeah. And that's also like been communicated, but I think that's a good idea in terms of can you satisfy your IRB and keep your study moving with that response. It's a very tricky study. The way we handled it was just to harass the IRB until they gave us an answer quicker, because it was kind of semi-public that we were told to stop the study, at least among our colleagues and the principal of that particular school. So last principle, justice, distribution of benefits and burdens. Want to just talk about professional interactions, funding sources, colleagues, collaboration, and credit for research projects. So one of the credit areas is publication. Community members may not care about being published in scientific journals. They may care more about giving the information back to the community. But nevertheless, if you have a community board and many CBPRers believe that you must have community co-authors, and you have these guidelines and the journal says you must sign something saying, everyone must sign something saying they participated, and one of your community co-authors is non-responsive. What do you do? Won't comment on the draft, won't give you feedback, just doesn't answer. You could substitute some of your colleagues for this too. What do you do? Yeah. That's definitely a solution. I think, yeah. Anybody else? Any other suggestions? Yes.
I want to find out why they want our community.
Okay. Good.
Which is what I do with students.
Yes. So yeah, I mean, it's going to take up extra time and attention to find out, do they want in, do they want out? Can you move ahead? So I just want to mention 2 last issues, one being global ethical issues working in communities. research ethics systems may not be developed the same way that they are in the US, in global communities, and questions of things like, demands for payments, gatekeepers, et cetera, in communities might arise. And there are plenty of stories about that. So those are just things to be aware of if you're working in the international space. And last is the internet. And this has come a long, long way in the last few decades. The questions of confidentiality, being able to protect participants from harm, using online consent, and the continually changing technology landscape. It really was only 8 to 10 years ago when if we wanted to collect data on a device, we had to give participants a device because they were paying for minutes and paying for texts, and we couldn't compromise their iPhones or whatever they had at the time. And now it's much more common to just have people use whatever they have, and it'll be something else in the future, I'm sure. So just to wrap up, ethical issues are dynamic, they're ongoing, there are really no easy answers. Oftentimes IRBs aren't prepared to deal with some of these issues, so you need to be prepared to work with them and to kind of know how well what you're doing meets expectations, ethical as well as legal expectations. And I just want to thank many of the community participants and colleagues that I've worked with, and you never know who you're going to meet out there. Thank you. Time for a couple questions? Yes.
What is the PI is a whistleblower suspects a PI of ignoring the protocol and doing something?
Oh, Holly would probably know the answer to that better than I would.
Yeah, I don't know that that's specific to community-based. I don't know that that's a specific question for this.
It doesn't really.
I'm sure that there's a link on the IRB website or on the Office of Vice Provost for Research website. I don't know it off the top of my head.
Yeah. Susan?
A clinical trial in the community. You talk about a community advisory board, but you might also have a data safety monitoring board where they were reviewing the data as it went along, and that would be considered very confidential.
Yeah.
There are often community people on various, not necessarily for something that's happening in their community. That's something that you have done. How do you feel about that?
I've had what you're saying is a community advisory board and a DSMB. They've been separated, generally because it might introduce, a different type of investment of the community member, community advisors, and the DSMB people. You want to be sure they have particular qualifications. So that would be
I was thinking of the issue of having an understanding about the confidentiality and
Yeah.
the differences start to emerge.
Yeah.
Would be awkward or difficult for
Yes.
the community to maintain confidentiality.
It would be awkward. Yeah, I mean, that is something that kind of more broadly affects if you have community members helping collect data, process data at every step of the game. That there has to be an understanding, and I would say there has to be some vetting. Not everyone's cut out for that. If they really believe that this is an outsider and my obligation is to my neighbors. Yes.
Do you think that all research should be community engaged? What qualities of the study do you think
I think that all studies should be community engaged, but it doesn't necessarily translate into having a community advisory board. It may be a matter of having key contacts that are, kind of gatekeepers and that are familiar with the community.
Thank you. Please join me in thanking Dr. Glanz.